इतना टाइम लगाया उसको ये चीज़ पढ़ने और वो चीज़ पढ़ने में, एक्चुअली जब आपका फोकस, अगर पहली चीज़ तो ये कि यू नीड टू अंडरस्टैंड वेयर यू आर एंड व्हाट यू आर एक्सपेक्टेड टू सी फ्रॉम योर लाइक मुस्तफ़ा से स्टेशन कभी भूल गए, जब स्टमक में है तो आपने क्या क्या देख लिया, ठीक है ना। अगर आप मीडियास्ट्रम में हैं तो आपकी कौन सी प्रैक्टिकली दो ही जगह होगा, तो इसमें से भी मेनली मैंने तो कभी एपी विंडो में कोई चीज़ ऐसे खास नहीं मिली, जब एपी में मिली है तो मुझे वहाँ पर भी कुछ मोड मिली गई इंडिया के एरिया में, तो हो गया ओके फाइन स्ट्रेट। बट स्टमक में इम्पॉर्टेंट है आपको, इम्पॉर्टेंट चीज़ें वाई इज किडनी इम्पॉर्टेंट, बिकॉज इट हेल्प्स यू ट्रेस द पैंक्रियास, यू नो where in pancreas you are. It tells you are in the tail of the pancreas or towards the tail of the pancreas. So that's what these structures become important for the pancreas, because that's your main interest. You're not there, you can pick up things otherwise, but I think you're not there to pick up kidney lesions or, to be honest, other things. You're focusing on that. And शुरू में ना जो normal EUS होता है, normal CBD अगर किसी पेशेंट की है या PD है, that is the most difficult thing in my opinion, because it's difficult to trace the CBD. Sometimes it's difficult to trace the pancreatic duct. It's really normal pancreatic duct 2-3 mm वाली तो वो कभी आपको एक दे देगी और फिर वो गायब हो जाएगी. Whereas when things are abnormal, they actually come and hit. So pick up cases that are abnormal. लेकिन नॉर्मल से सीखने की कोशिश ना करें, मेरा मशवरा तो यही है, बिकॉज देन यू विल ग्रेजुअली गेट टू नो कि आप क्या कर रहे हो, किस तरफ जा रहे हो. दीज आर थिंग्स दैट कम बाय प्रैक्टिस. यू नीड टू गो बैक एंड अंडरस्टैंड एंड प्रैक्टिस. Here, back and movements have to be there all the time, but very subtle and slow. So when you're moving, it should be slow so you can actually follow what you're doing. They're not purposeless movements. They're purposeful movements. So you know when you're doing clockwise or counterclockwise, what are you going to do? When you pull the scope, what happens to the lesion? Or when you advance the scope, what happens to it? How do you bring the lesion in the area where you want to actually do the biopsy? How do you avoid the vessels? Those little movements will teach you with time. I don't think EUS is difficult, but obviously it's complex.
Hello, Dr. Saad, can you hear us? Can you hear us?
Hello?
Yeah, can you hear us?
जी जी.
Sir, can you hear us?
Yeah.
जी. मेरी आवाज़ आ रही है? Can you hear me? Okay.
We'll just start your transmission. I'll just tell the team the case and then transmission शुरू कर देते हैं.
Okay.
All right. The first case that we're doing is abdominal pain, nausea, vomiting, and some weight loss as well for the past 2 months.
Can you move the mic close? Can't hear well. Yes.
She's had similar complaints of abdominal pain, nausea, vomiting on and off for the past 1 year, but currently the severity of the symptoms was too much. So the radiology findings for this patient, I'm only going to be mentioning the relevant investigations. That showed the pancreatic had appeared to be swollen and heterogeneous with mild peripancreatic fluid collection, and that was causing slight abutting in the body. And she ultimately also had an MRCP that showed that her PD was dilated 7 mm. So just to have a look at the image, we've kept the best image that we can find so we can see the similar findings. If you can see, the pancreatic duct appears distally quite dilated and it's slightly tortuous, and overall it is quite prominent. If you look at the anatomy of the pancreatic duct, there seems to be a Z-shaped anatomy right here. It could just be the loop pancreatic duct. The plan of action right now is to just assess the pancreas. Her IgG4 levels were 431, which are well above the normal limits. This is a second image. So just appreciate the anatomy of the pancreatic duct. You can see that it is dilated, it's prominent, and distally it's more dilated than proximally, and throughout its course it's slightly tortuous as well. So we'll be proceeding with the case now, and transmission agar video ki kar dein.
Check है सारा कुछ. सर वो वाला है या उधर वो वाला है? ये वाला कैमरा? अच्छा अच्छा ठीक है। तो कैन दे आर गोना पुट दैट ऑन देयर राइट? वो स्क्रीन पे जाएगा ना अभी?
उधर तो यही हमें ये नज़र आएगी आपको।
नहीं बट वी विल गो ऑन दैट स्क्रीन।
स्क्रीन पे लाइव कर दें।
स्क्रीन पे लाइव कर दें।
लाइव कर दें। Can we get it live on the screen please in the
ठीक
seminar room?
अभी निकाल।
रूम को लाइव कर दें वहाँ पे ना।
अब पेशेंट ठीक है? हाँ कोई 15-20 मिनट्स लगेंगे पूरा प्रोसीजर करने में। ठीक ठीक है। ये कैमरा जो है ना मेरे हैंड्स पे ये दिखाना है, स्कोप दिखाना है, ठीक है? और can they put like yeah, one this image and the other is a EUS image, right? That's what they're trying to do.
Can we have EUS image on one screen and Khalid by hand on the other screen?
I think while they're trying to, Saad bhai, Gyas bhai, you can hear me? Can you raise your hand? Yes? Yep. So what I'll do is like when they try to fix the EUS image, I'm just gonna go over the scope quickly in the meanwhile. So you remember earlier when I was mentioning, this is the cord of the scope and this is the transducer right here. So they both are on opposite sides. So if I'm holding the scope straight here, these cords, they are the umbilical cord is facing towards me and the transducer is facing completely opposite side. And other thing is we talked about the camera. Now turn the light on. Okay. You see where the light is on this, turn the light off now. The light is there, light source, camera, transducer is in front of it, almost 1.5 to 2 centimeter. In this case, we are using a balloon on that. Other thing which I do is, I think I need a EUS and endoscope image, but they are working on that. If I move the big wheel towards me, the scope becomes like this, like that. So the way I intubate the patient is with the scope, I flip it upside down like that, just like an oral airway. You don't have to do that, but that's how I do it. So I will go into the mouth, and then when I'm hitting the back side of the throat, I will flip like an oral airway, the way we do that. So this way the tongue does not come in my way, and as soon as I flip the scope, it goes into the right into the upper esophageal sphincter, and gently then moving a scope around, rotating it a little bit takes me into the esophagus. So I will wait for EUS image to show up and then we'll start. Other thing I did mention earlier about EGD scope, front view, Dwarner scope, side view. You are looking at the ceiling, moving forward. For the EUS scope, it is the camera is at 45 angle. Just imagine where the ceiling and the wall meeting, and that's where your camera is, but your probe is in front of your camera. So just wanted to repeat what we talked already. So let's wait, let the images come up, and then we'll start. Okay. आ रहे?
सर ने वेट कराया तभी कर रहे हैं चेंज कराया
ओके, इसके वो लगा दो, लुब्रिकेंट लगा दो।
ऑलरेडी
लगा हुआ है? अच्छा अच्छा। And other thing, the way our processor is in our unit, that is on this side, on the left side. So I put this code behind me when I'm doing there, but here, because the processor is on our right side, so I will keep this code in front of me. So I think we are ready for this. So endoscopic image first. I will rotate the scope upside down like an oral airway. Other thing is I hold the scope close to 25. Upper esophageal sphincter in a majority of the these patients is probably between 15 to 18 centimeter based on their height. So I want to hold it close to 25. So when I get to the upper esophageal sphincter in the oropharyngeal area, I don't want to be too close, and then patient is gagging and I'm trying to move my hand back on the scope, and don't want to be too far, so and the scope is too floppy and not moving around. So I usually hold the scope close to 25. Okay. We'll go ahead and start. So I did the same way as I mentioned earlier. And I went to the, flipped the scope. After I flipped the scope, I went over the tongue like this, and then flipped it. That went straight into the upper esophageal sphincter area, and gently rotating the scope right and left, I was able to get into the esophagus without any problem. Now, if you look at the endoscopic view, ये बेड ऊपर हो जाएगा थोड़ा सा. Okay. If you look at the endoscopic view, I'm not seeing the whole lumen. If I see the whole lumen of the esophagus, that means my scope is like this. And if then I'm trying to move my scope like that. So I'm just seeing half of the lumen with the EUS scope, or very little amount of the lumen, and that is the ideal really way to pass the scope in elderly patients. Sometimes they have a stricture, and if you pass it too quickly, you can damage the esophagus, cause a perforation or bleeding. So you pass the scope very gently through the esophagus. Once I get to the GE junction, what is that? Anybody sees something different? So can you go back to the big endoscopic view a little bit bigger, please? Make the endoscopic view bigger. Okay, right there, just there, right there. Does anybody notice something different in the stomach? It's a huge compression, extrinsic compression. I don't think that was on the CT or MRI, right? Okay. So anyway, so I think we'll talk about that in just a second. So once you are at the GE junction, what I usually do is I inflate the stomach. I know we talked about that air is not really a friend of EUS, but what I do is I inflate the stomach. I will take my scope towards the opposite wall of the stomach. Once I am there, moving the big wheel towards me. Now you can make the EUS image bigger. Okay. I'll suction the air out of the stomach, moving the big wheel towards me, takes me to the left lobe of the liver. If you look at my scope, wheels are facing up, scope is really straight, and that is, I call, a neutral position of the scope. So I will move the big wheel a little bit towards me, pull the scope back, that takes me to the left lobe of the liver, and if I need to put a little bit fluid into the balloon, I'll do that. As you saw that, I put a little, because there was some air, so I put that water into the balloon. That helped me a little bit. But as I Yasab mentioned earlier that you really don't have to use the balloon. So from here, what I will do is I'll pull the scope back a little bit in a way 2/3 of the liver is on the left side of screen, 1/3 is on the right side of the screen. My scope is at 180, laying flat, wheels facing up. Now I will do is bring the scope at 90 angle like that. Big wheel towards me, rotating the scope to the 90. Once I get, you see that there is a big vascular structure inside the liver. When you see a liver around that big vascular structure, that's a IVC, and it is easily compressible. But that's not what we are looking at. We're going to keep rotating until we get to the aorta. So what I did right now is, it's going to be a little bit challenging in this case because there is so much compression in the stomach. So I think we'll do a normal, a little bit relatively more normal examination at other time, but just few steps I can go through. So you saw earlier, scope was laying flat. Now scope is at 90 angle, and I'm right at the aorta. Once the aorta is in like a nice landing position. So once I am at the aorta also is not as compressible as it was before. The IVC was compressible. IVC had a liver on both sides of it, aorta does not. So once the aorta is in a nice landing position, big wheel towards me a little bit, gently advancing the scope, and rotating it right and left. Do you see the vessel here coming off that? First vessel right there, the way Mustafa showed in the videos, that's a celiac artery. Sometimes the celiac artery comes off the side of the aorta. So that's why you have to rotate right and left a little bit to make sure that you get to the origin of the celiac artery. Celiac artery divides into the 3 main branches. Left gastric. Anybody else wants to mention the other 2 from the trainees?
Guys, anybody?
Those three vessels.
Branches. Left gastric, splenic, and hepatic artery proper, common hepatic artery, yeah.
Okay, so here, so
this image is the most important images in the EUS, having the aorta coming down from there and the celiac axis. If you can get this image, you've done half of the EUS, okay? So this is one of the most important images. And just we always have this tendency of trying to correlate it with the CT. Forget about the CT image.
Shazad, can you speak in the mic? I can't hear you.
Sorry, we were just trying to emphasize the importance of this image of you showing the aorta and the celiac axis, as this is like the home station. And if you ever get lost, if you can get this image, you can usually find your way.
So what I'm pointing at right now, this is a celiac, and you see a branch coming off that. What is that?
Yes, we can see that. Left gastric is the answer here.
Okay, so that's the left gastric. Sometimes it's a trifurcation. Left gastric, splenic, and common hepatic. They all originate at one time. Majority of the time, left gastric comes off first. Left gastric is going towards the right of the screen. And then the rest of the trunk divides into splenic and common hepatic. Splenic goes straight. Common hepatic dips down backwards. So the goal here is to follow the splenic. By that I mean, if you look at my scope, I'm just using my shoulders, my left shoulder, and doing all these movements right there. You see that? Just gentle movements back and forth, and that's the movements you're gonna do. So here, once I am at the main trunk, now I will gently advance the scope and release my wheel. What that does is that takes you to the pancreas. But here we don't have the pancreas, unfortunately. There is a large collection there, and it's quite large. And I don't think we're going to be able to get the full. I will go to the duodenal bulb and take a look at the head of the pancreas, but here you can see how big this collection is. Does she have any symptoms of pain?
So
Yeah.
there's a question. Can we just comment on the structure of this, the echo texture and the formation of this cyst? And
Yeah.
is there any way we can quantify the amount of solid, you know, there is in? What would you say? How much is this solid and how much fluid?
It's if you look at it, like there is a little bit difference in echogenic, but mostly echogenicity, but mostly it is pretty same. There is a little bit hyperechogenicity at the lower part of it, and more like it's not really, it's a lot of debris in there, so it's not clear anechoic, and that really shows it, and you can see the movement in there as well. So it really shows there is a liquidified necrosis in there. There may be some solid component towards the surface down there, but majority of it, I can see that movement in here in the fluid. So most of it basically is really all liquidified. And there is a nice wall around it. You can clearly see the wall around it. Let me decrease the gain a little bit. So you can see the wall. It's a really nicely walled off. If there is a necrosis component, which looks like some there, so walled off necrosis with mostly a fluid component. So that's here. I unfortunately can't show you any pancreas because I don't see any pancreas in this area. So let's go to the duodenal bulb.
So Dr. Khalid, just on this point, whether it's a walled-off pancreatic necrosis versus pseudocyst, you mentioned that there is necrotic area. There's some argument that if you have less than 40% of solid component, you can just treat it like a pseudocyst. Is there any way you can just visually quantify that amount, or is just a guesswork?
I think it's maybe if you have any way to do that, you can tell me, keeping in mind it's a two-dimensional image with the EUS. It's not a three-dimensional. Yes, you can get an idea about that. I can see like the lower part of it, and on the sides. Here there is a necrosis, you see that. But when I go towards the center of that, there's more liquidification. And there's some at the bottom surface, there may be some necrosis, but majority of it, like I can tell you, seems like majority of it is liquidified, 70–80%. But it's a two-dimensional image. So with the CT, you may have a better idea with the overall quantity of each of those. But with the EUS, you can estimate, which I think in this case, we can treat this likely as a pseudocyst. Okay. Than majority of the, not majority of the necrosis.
Okay, thank you.
So the question is a debris and necrosis. Debris, I think, would be more liquidified. Necrosis would be a little bit more solid. So these are some terms which you use interchangeable. So it's, I think this all is not pure fluid in there. You can call it debris if you want to. It's a liquidified necrosis.
Dr. Khalid, can you hear me?
Yes, I can.
Okay. So my question is about the patient management. If the patient is symptomatic, look like to be post-pancreatic maybe, so would you like to go for the drainage or wait?
Who is asking?
I'm Dr. Masood Karim.
And you are observer or you are a
Observer.
Okay. So continue to observe, and we are gonna discuss about the imaging. If we start talking about the management, that's gonna take for too long. We can talk about that later. Patient is, a simple answer is, if patient is symptomatic, yes, we wanna do something about it, but let's focus on what we are doing right now. Yes, this patient needs some sort of treatment. We can talk about that later. And if they want, we can drain it too. So purpose is diagnostic EUS for you right now. Okay. So not the therapeutic. So, but we will work on that. I think whatever team decides, we'll do that. Okay. So
we don't have the consent from the patient first. We didn't expect this to come. So we're going to take a consent and then plan it another time. Because we don't have a consent, we will not proceed with this right away.
Thank you. You could have said that earlier. I didn't have to say so many things.
So Khalid is trying to get into D1. Once we're there, we will be able to see the pancreatic duct better there.
Okay. Maybe. So what I'm going to do is,
so maybe there is compression there.
So here you see the pylorus right there. For the duodenoscope, you make it like completely at sunset position. With the EUS scope, you can see a little bit of it. But if I am looking at it and I try to go in, sometimes what happens is your transducer that is hitting at the bottom of the entrance, so it's not gonna go in. In this case, when I am close to the pylorus, right there, like few centimeters away from that, I will move big wheel towards me so I can align that pylorus with my transducer and then gently move in. You see that? I already had aligned that before I got into the duodenal bulb. So right here, that's a duodenal bulb. It's giving a little bit resistance, the scope movement. The reason for that is majority of the stomach is occupied by that extrinsic compression from that cyst and necrosis. But once you are into the duodenal bulb, the goal is, I inflate usually to see where the duodenal apex is. Take my transducer right there into the duodenal apex. Goal is to put the transducer in left upper corner for me. So I'll put the transducer there, big wheel towards me, use the suction then to collapse it, and here let me just put that up. I'm looking for three basically structures. One of no, not that game, the vestibular. So I'm basically, when I do this movement, I'm looking for three structures. Either I'll find all those three, or I'll find one or two, and as I said, all those three. So those three structures which I'm looking for is the portal vein, the bile duct, pancreatic duct. These are the three things I'm looking for. Obviously, the pancreas is going to come with it, but if I find one of those, I can find the other two. So let's see what, once again, I'm in the bulb, putting my transducer into the duodenal apex. Goal is to put it in left upper corner, using a suction and rotating the scope sometimes to the right. So here, when I rotate the scope to the right, I see a bile duct right there. Right here, I see a portal vein right there. And majority, you see this all? That's all that collection which you were seeing earlier. So now here, this is actually a good view right here. That we'll show in another, either Mustafa or I or somebody will show in the other patients. When you look at from the stomach, splenic vein comes like that, SMV comes like that. They make a portal vein, and portal vein goes downwards like that. Here, that orientation, just imagine from the stomach, you are looking from the top down. From here, the scope is along the greater curvature, resting up and looking upwards. Just imagine that. So the orientation changes. What that means basically is, portal vein is right here, bile duct is here. Now portal vein this way is going towards the liver. But if I come rotate to the right, and other thing is, like, you see that how I'm just rotating with the left hand the scope. So here is the portal vein. This would be a splenic vein here. SMV on the other hand is right here. SMV, splenic, getting together, making a portal vein. So this is important, completely different orientation. Now the pancreatic head is in this area, pancreatic neck is here, pancreatic body is here, and tail is here, which was completely opposite of what you see in the from the stomach. So here, if we find the bile duct right here on the top, if I follow that towards the liver, I'm going anti-clockwise, following that anti-clockwise until I get to the liver hilum. You see the liver all around there now? To go towards the ampulla, I'll do a right torque. And other thing, important thing is, whatever I want to examine, whatever structure I want to examine, My goal is to keep that between 5 and 7 o'clock position. I don't want it to be on the side. So you will see my goal here is going to be keep the bile duct right underneath the transducer. Does she have a stent, guys?
We don't have a history.
I see, it looks like a stent there, right there. Okay. So she may even have, looks like she had a stent there. So, okay. And bile duct is kind of decompressed as well. So I think there is some. Right there, that is a stent. So anyway, I think this is probably not the best patient for the normal EUS examination because there is not much normal there. We see the portal vein. I do see some of the pancreas right here. There is a stent in the bile duct right there. Yeah, there is a stent in the bile duct right there. And stent now it ends into the duodenal lumen. Going back to follow that bile duct towards the liver hilum. Right there, stent ends in this area. And that's we are at the liver hilum right now. So Saad bhai, I think that this is probably the best exam we're going to get Vyas bhai, in this right now. But I think we'll go to the some other patient and then we can.
I think your mic fell off. We can't hear you. Second portion, the Kadnagar.
It's not working.
Do you want to show us the second portion view?
Yeah, give me 1 second. They're fixing the mic. Okay.
The patient had actually an ERCP done.
Yeah.
A stent placed, which the patient didn't mention to us. There were no reports given to us.
Okay, no
so
problem.
all we had was the last MRCP that we had of 20th August. Had an ERCP on the 24th of August. And
Yeah.
which obviously we didn't know about, and the rest of the things.
Well, we see the
wasn't
stent right
mentioned.
now anyway. Endoscopically, you can see the stent right there.
But I think it was a good demonstration of identifying a stent on the EUS, and also it actually allows you to see the course of the bile duct. And for learners, I think there's still value in this because you're able to see the bile duct, the stent being there all along gives you the view of the bile duct from the valve.
Yeah. Okay. So now
I think that raises a question because is this post ERCP problem or complication that we are seeing following pancreatitis, or is this? So we'll give you details of where the ERCP was done, not done here. So we don't know.
okay. So and I can quickly go through the second part. So you move the scope gently through the duodenal apex into the second part of the duodenum. I usually bring the scope into a short scope position and try to see papilla. If you can, well and good endoscopically. If you can, don't worry about that. So once your scope is in a short scope position, here we do see the papilla kind of. So what I'll do is I'll put my transducer right on top of that. What I did is I didn't really put my transducer on top of it because I put the camera on top of it. My transducer is still further away from that. So I'll have to pull the scope back a little bit and to get my transducer close to the papilla in the second part of the duodenum. I think Mustafa may demonstrate it in a different way because that's how it's our ways with different ways doing the same thing, trying to achieve the same thing but maybe in a different way. So what I do is I will ask, the way I will teach you is I will ask to look for 5 different structures, and out of those 5 structures, one is aorta. That is in the middle of those 5 structures. Here you see the aorta is right here. Where's the Doppler? Right there. You can see even it's the way it's pulsating. My scope is right here straight right now. If I go a little bit to the left, you see the IVC right there. If I rotate the scope anti-clockwise a little bit further, I will get to the right kidney or segment 6 of the liver. The liver which touches the right kidney is segment 6 of the liver. We'll go over the liver segment in some of the other cases, but this is a right kidney right here. IVC right there, aorta right here, further rotating to the right or clockwise rotation. I get to the pancreas right here, but really majority of the pancreas is kind of all really necrosed. And but the next thing which we were looking for is the stent or the bile duct right here. You see that stent right there. The pancreatic duct is going to be further clockwise torque. It should be here, but I really don't see any pancreatic duct. So basically aorta, if you go to the left of that, it's going to be IVC. Further left is going to be the right kidney. If you go from there, from the aorta to the clockwise torque, that's going to be a stent there, and then pancreatic duct. So here, except that aorta and IVC and the stent in the bile duct, we don't see any other major pancreas left. So here I can see the stent right there. Right there, you see, oh, there is a PD. I do see a part of it, right close to the head. So, pancreatic duct, look at my scope position. My right hand is not on the scope, just the left hand. PD, anti-clockwise, stent or bile duct, further anti-clockwise, aorta. Further, if I go, that's going to be IVC. I need to pull it back a little bit. But this is the structures we'll show some in other patient as well. So aorta, IVC, right kidney, aorta, bile duct, pancreatic duct, further to the right clockwise, that's going to take you to the unsnate process of the pancreas, and you will see a splenic, you will see a superior mesenteric vein here and a RD right here.
Khalid?
G.
Saad. Khalid, ये बताएं कि I mean there was a suspicion or a provisional a possibility of autoimmune pancreatitis here. The pancreas doesn't look like that, does it?
Now, first of all, we don't see much of the pancreas.
Whatever pancreas you've seen, that is.
This one does not look like an autoimmune pancreatitis to me. And this is the only pancreas I'm looking at. Pancreatic duct right here. These are the mesenteric vessels right there. I don't see any, like the duct in the autoimmune pancreatitis in this young patient, you barely would be able to see any pancreatic duct. And this head area would be very, very bulky area. And so I don't see that. And necrosis or collection like that in autoimmune pancreatitis, usually that's not the presentation. This is more like either a gallstone pancreatitis or a post-ERCP pancreatitis, so I don't know what that is.
Yeah, I was going to say common things being common. Do you want to show us the gallbladder if you can identify it? So
Yeah, if I can.
if there's sludge or debris inside.
No, the torquing
There's
is
a
at the
stent,
hand,
so
not the
who
shaft.
knows?
जैसे वो
वो तो अब
colonoscopy में
sludge stent की वजह से भी हो सकता है. But I think
वाली नहीं होती ना, सिर्फ
the
आपने
point being, I
hand से
think
clockwise, anti-clockwise
we have to think common things first, and the most likely etiology still would be considered to be
There's a lot of
biliary.
ascites as
Yeah,
well.
ascites too. It all depends on timing. I think
You guys saw the ascites as well, so it's hard
Yes.
to really even see the gallbladder right now. There's so much extrinsic compression.
okay, that's
Yeah,
fine.
I don't even see it honestly.
No
But-
problem. No problem.
And for the gallbladder, usually it's when you are really close to the pylorus on the lesser curvature, this may be a compression from the gallbladder.
I think it's
It's all ascites there.
it'll be really hard to say with certainty if it's ERCP or just natural progression of disease.
Yeah, it's hard to see most of a gallbladder. It's all collection circulation all around that.
Yeah. That's okay. I mean, if it's visible, great. If not, that's okay.
हाँ जी, आप क्या कह रहे थे?
मैं कह रहा था जो clockwise anti-clockwise is it's just this movement, not the
Yeah,
just
not with the right hand.
on-
So Shanil wanted me to point out is the clock and anti-clockwise movement. Mustafa already mentioned that it's really your left hand which is doing all that, not the right hand, not just the way you hold the colonoscope. You're doing that with the colonoscope, right and left torque sometimes, but with the EUS scope and even with the ERCP scope, it's the, your left hand which is doing clock and anti-clockwise. And it's really this, using your elbow here or your shoulders like that. And whatever you are doing at this end of the scope, ideally that should be transmitted all the way to the other end of the scope. And that is only gonna happen if your scope is in a kind of a straight position, there's not too much torquing on that, and scope is like a comfortable, in really a comfortable position. That's the only way it's gonna happen. If you are like this or like this and do this, this is not gonna do anything and transmit that towards the end of the scope. If you're like Saad Bhai, you can stand close to the patient, or like him or Ghiyas Bhai or even Mustafa, you can hold the scope like that. If you're like me, you can step behind and one step away from the patient to keep the scope straight. And that way you can transmit whatever you are doing at your left hand to the end of the scope. Okay? So I think Saad Bhai will stop there. We can determine what we're going to
Yeah.
do with regard to the management later with this patient.
Yeah,
because
so what we've done is, because this case is obviously turned out to be more complex than we expected and difficult to show the gastric thing. So next patient हम एक और ले रहे हैं. We'll request one of the faculty to demonstrate, Khalid or anybody, one of you.
Saad Bhai, you want? I was asked, should I show a mediastinum?
You can show the mediastinum, of course you can.
Okay, so quickly for the mediastinum, scope needs to be straight. I'm at the GE junction, you can see endoscopically. Majority of the time, if I bring the scope close to 30, and I'm not even looking there, I'm just gonna look at the scope. If I bring close to 30, many times, like more than 90% of the time, it's gonna take you straight to the left atrium. So, and again, it depends on the patient's height too. Here, it's close to 29. Scope, straight, big wheel towards me. I see the left atrium there. I will pull the scope back just a little bit to bring the left atrium to the left of the screen. You can see that left atrium here, mitral valve there, left ventricle there. And if I rotate the scope to, you see the aorta right here and right pulmonary artery there. If I pull the scope just a little bit back, if you look at my scope, big wheel is towards me, it's just hugging the esophageal wall and pulling it back just a little bit, the space between the left atrium and the right pulmonary artery, that's the S7 or subcrina. From here, if I pull the scope back, big wheel towards me, you see the aorta right there? Aorta right there. Patient is a little bit uncomfortable, but aorta is right there. Once aorta is about to disappear to the left side. I'm right at the aortic arch right now. I will push the scope just 1 centimeter in, big wheel towards me, and that would take me to the AP window, pulmonary artery, aorta. If I push a little bit away, you see that? This is like sometimes it's like a sunglasses sign. So both are one on one side, one on the other side. And the space between those on EUS we call a AP window, but that really is a little bit down than what we really look at. If I come further up, move the aorta, you see there is a vessel coming off that. That's the left carotid artery. And there is another artery right behind it. That's the left subclavian. If I rotate further downwards, this is another one. That's the subclavian. So, and not subclavian, I mean brachiocephalic. Left carotid, left subclavian, brachiocephalic. So you can, if I pull further back a little bit, from left carotid, you see the nice thyroid gland right here. That's the thyroid gland. This is the image from the trachea actually on the other side. I'm pushing the trachea a little bit to the side, and that when I do that, sometimes patients cough too. That's exactly what happened earlier. But this is the thyroid gland right here, and it looks just like pancreas, and sometimes you can even see the nodules there after they are. Many times the thyroid, you examine it better on the way in, but you can clearly see that right there is a thyroid, and I'm now into the oropharyngeal area and scope is on. Okay. Any questions? Gasbhai, Shahzad.
Thank you very much, Khalid bhai. That was an excellent demonstration. But it also shows that the importance of cross-sectional imaging and reviewing it prior to doing in EUS, because suddenly you can sometimes be given some surprises.
Yeah.
Excellent.
Yeah,
Thank
you would be able to identify the surprises only when you know the diagnostic EUS, and paying attention to every single structure and make a habit. I think Mustafa mentioned that if it's a sedation is an issue or patient is critical, just go to a focused exam, try to achieve what needs to be done first, but make a habit to do a full exam. And that stations, for me, the station is stomach is a station, duodenal bulb is a station, second part of the duodenum is a station, and then esophagus is a station. I don't go with any other stations. Just make your own stations. I start with the GE junction, celiac, SMA, pancreatic body, tail, neck. My second stop, instead of station, I call it stop. My second stop is going to be duodenal bulb. Then your main structures, you are looking at the portal vein, bile duct, pancreatic head, pancreatic duct. Go to the second part of the duodenum. Again, same thing, bile duct, pancreatic duct, aorta and the structures around, uncinate process, mesenteric vessels, and then coming back. I look at the mediastinum on my way out. So that's how my stations are. And you can develop your own stations, but try to keep doing every single time, all those stations, so you don't miss anything, and just make it as a habit.
Khalid bhai, there was
you.
one comment. You didn't use the balloon during this procedure.
I did use a little bit in the beginning, but you don't have to. Sometimes this balloon, what that does is just putting that on, and just a little bit fluid in there, get rid of that air which sometimes comes around the transducer. So that's what I did. Maybe I thought I mentioned that I used a little bit balloon fluid in there, but maybe I didn't notice that.
Thank you very much.
Okay.
Thank you. Just another important point.